Assalamu alaikum, everyone. Is my voice clear?
Walaikum salam, ma'am. Yes, I'm clear, ma'am.
Okay, so proceeding with the spinal ependymomas today. And I'm sorry for missing the session on Thursday. It has been a really, really packed week in my institute, and I missed all of you and the session, I think, just as much as every one of you. So, without further ado, we are proceeding for spinal ependymomas today, and I will see if I can cover some surgical nuances as well. So, I'm sure that you all remember the classification. Do you? Or do I need to go over it again? Dr. Kingsley, your mic is it's not working properly. Okay, so I'll just briefly go over the classification again so that if by the end of ependymoma series, you all are very fluent in how ependymomas are classified in CNS 21. So we have supratentorial ependymomas, we have posterior fossa ependymomas, we have spinal ependymomas, and subependymoma. When we are talking about supratentorial ependymomas, these are Zefta fusion positive or YAP1 fusion positive, and whatever is left over goes here, NOS and NES. We have covered the supratentorial ependymomas last week. Then we have posterior fossa ependymomas. These are group A and group B. That is something we have also covered. Today we are going to cover the spinal ependymomas, the classic variant, and the Mycian amplified variant, myxopapillary ependymoma and subependymoma. I think I'll cover both of them tomorrow, inshallah. So, are we clear with the classification? This one's easy, right? This is a lot easier. Wait till you come to medulloblastomas. So, uh, this one is really easy today because all the information is written down here. But does anybody still want to read it? Read the imaging?
Yes, ma'am. The image A shows the sagittal T2 weighted image, contrast enhanced image, and it's showing the diffusely enhancing
Which
well-defined
one is the
mass.
contrast enhanced image?
Uh,
What
sorry,
is A?
A is the T2 weighted image, ma'am.
Okay,
T2.
and what about B?
B is the T1 with contrast.
Exactly. B is the T1 with contrast image because you see the CSF is right here and this is T2 weighted classic sagittal section. Okay, so proceed.
There are two hyper intense lesions, one at the level of C5, C4, C5, and the other at the level of C8, C8.
Okay.
And
Do you think this is these are two different lesions or this is a single lesion with a lot of with a varied presentation? What do you think? This is a single lesion or two lesions? Take a really good look again. And don't look at what is
yes,
written.
ma'am. Yes, ma'am. The lesion is the showing at the level of C4, C5 is a lesion showing a neoplastic lesion, maybe a neoplastic lesion, and the second lesion which is showing downside at the level of C8, it might be syringohydromyelia.
Oh, yes.
Syrinx.
And if you see the post-contrast images, you see that C2, C3, this starts from C4, C5, C6, C7, and T1 sort of, but C7 is a better option because this here is the lesion if you see post-contrast images, right?
Yes, ma'am.
So where do you think is the lesion?
Uh,
Is it intra
more
medullary? Is it intradural? Is it extramedullary? Where do you think this is?
intradural, intramedullary.
This is an intradural intermedullary lesion. What
Yes,
else
ma'am.
could you have told me to keep yourself safe if this was not
Yes,
an
ma'am.
informal discussion?
Uh, the other tumor might be astrocytoma.
No, 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 no. What I meant to ask was that if you're asked about the origin and the location of the tumor based on only on the sagittal sections, you can always ask for the axial imaging as well, because without axial imaging you cannot be sure if this is intradural extramedullary and which is centering the cord, or this is intramedullary. I think you get
Yes,
what
ma'am.
I'm
Yes.
trying to say. For that, you would need axial sections.
Yes, ma'am.
So
I need
as long
ex
as, yes, as long as this is an informal discussion section, rounds, or when you're discussing it with peers or colleagues, it is completely fine. You can take a guess. But when you are when you are in more formal setups, and for example, if you're appearing for exit exam viva, the better option is to ask for axial imaging. Because if there is an extramedullary lesion and it has completely displaced the cord, in the mid-sagittal section, you would still see the lesion and it will be mimicking the intramedullary tumors, right? So, a good
Yes,
way
ma'am.
to describe this imaging would be T2 weighted images, sagittal sections of cervical spine, also showing the craniovertebral junction and upper portion of the cervicodorsal junction as well. And I could see a relatively well circumscribed lesion on T2 weighted images, which is centrally located. Looks like it is expanding the cord. There is a cystic portion at the top of the tumor associated with peritumoral edema, uh, which is overlying the cord. I can see that the CSF column is completely obstructed at the level of the lesion, and below the cord, there is some syringohydromyelia as well. Okay, so when we transition to the T1 post contrast imaging, we say that the lesion is taking up contrast, but it is not vividly enhancing, and I can still see a cyst at the top of the tumor. So someone is writing in the chat. Let's see who is that. Axial gut. Okay, so yes, Dr. Amir, today's topic is not spinal tumors, spinal ependymomas. We are continuing our ependymoma discussion from last week. So yes, this is this is an intratumoral cyst. It is also called a satellite cyst when we are talking about ependymomas. This here is springohydromyelia. This is the cord edema. Okay, am I clear?
Yes, ma'am. Yes, ma'am.
Okay, moving on. This is the second case. What do you think? Can someone else volunteer for the imaging? If no one else does, Dr. Mustafa can still take a shot.
Yes, ma'am. This is the sagittal MRI of the cervical spine, showing the hyper intense lesion at the level of C7, T2 weighted image, along with a cystic portion at the bottom, and also causing the obstruction of the CSF flow. Uh, uh, the second image is the
It's post
T1 weighted image.
contrast. Yes, T1 post contrast.
T1 with contrast, showing the patchy contrast enhancement, along with the cystic portion at the upper part of the lesion, also causing the obstruction of the CSF. Uh,
Yeah, so this is centrally located. It is expanding the cord. And I wanted to ask, how did you say that this was a cervical region lesion?
yes, ma'am. When we see at the uh, yes, the upper vertebra showing at the
Yes, you can
top
still
top.
justify, but when you're not, you can justify with this. Is my cursor, this pen is visible, right? You can justify it with this shape. This is this is most likely representing the shoulder, the neck junction. So this can be
Yes,
justified, but when you are describing radiology, do not take these wild bets. I
yes,
think,
ma'am. Yes, ma'am.
Mustafa, I keep uh, telling you this again and again. Yes, trachea and
Thank you.
pharynx are visible, so this is
Yes,
justifiable. But you cannot comment on exact vertebral levels because you have not been given any markers, both above
yes,
and below.
ma'am.
So as long as it is
Yes,
an informal discussion, it is completely fine. But if you are sitting in an exit exam, or if you're discussing this in a more formal setup, avoid commenting on the landmarks, or always ask for better images or for landmarks. So
Yes, sir.
we are going to come across two different types of cysts. There are two intratumoral cysts and there are satellite cysts. What I mean by satellite cyst is what you see here. This is at the periphery of the lesion. It can be just above the lesion, it can be just below the lesion, but it is usually located at the peripheral edges. Intratumoral cysts are usually within the tumor substance in itself. You will see those examples as well. So this is another image. If you see somebody has used pregnant cord, I have never come across this term, by the way. So I'm sort of amused to have come to know about this. So this is again a mid-sagittal section, and we can see that the lesion is conveniently expanding the cord. The CSF column is obstructed, if you see this, and there is a cyst at the top of the lesion, and this is hyperintense on T2. Moving on. Ependymomas are typically slow-growing tumors. They arise from the ependymal cells which line the central canal or the phylum terminal. Why did I include this line? Because I was asked this question during a mock exam, that how do they arise? So it's always a good idea to remember where these are arising from. While astrocytomas are the most common intramedullary tumors in children, ependymomas are the most frequent in adults. Different percentages are recorded in different literatures, sometimes 60%, sometimes 70%. So that is not as important. What is more important is if it is an adult, it is more likely to be an ependymoma. Most are intramedullary. Why are we discussing this when we have this general notion that ependymomas are intramedullary tumors? Can someone answer this? Why did I use the term most?
Because they can be at the cornus medullary level as well. Commonly is the myxopapillary ependymoma.
Yeah,
think.
that's one reason. That's one reason. But that is for myxopapillary ependymoma. We are discussing the classic spinal ependymomas right now.
Oh, okay. Sorry, not sure, doctor.
But that can still be counted. The other reason is sometimes when ependymomas are Mycian amplified, they can appear intramedullary with exophytic components and sometimes extramedullary. So using the word most is the safest bet. Most are intramedullary tumors. They tend to be well circumscribed. Why is that important for us? Because we get to have a really good shot at gross total resection if it is a WHO grade 2 tumor, because grade 2 tumors are more likely to be well circumscribed. They are more likely to give us good surgical planes during the microscopic resection, and gross total resection becomes a very good possibility. Majority are WHO grade 2. Grade 3 is rarer, but when grade 3 is involved, the prognosis automatically downgrades. Ependymomas favor cervical or cervicothoracic levels. I think we all know this. So this is their one of the most common presentations, dissociated sensory loss. Why does it happen? I think I should not have written this. I've already written the reason. But can someone else want to comment why dissociated sensory loss happens?
As they are intradural and intramedullary, they commonly affect the central portion of the spinal cord, and therefore there is preservation of the proprioception and the loss of pain and temperature.
Yes, so dissociated sensory loss can be used in two different contexts. One is that we use in the Brown-Sequard syndrome. If all of you remember, we also use dissociated sensory loss there. And there is ipsilateral loss of posterior column sensations. There is contralateral loss of pain and temperature, right? That is one form of dissociated sensory loss. The type that we are talking about here is patients retain the posterior column sensations and they lose pain and temperature sensations. So they might have painless burns. They might tell you that they keep getting burned, or that they keep having these injuries, minor injuries on their limbs, and they don't feel anything about it. So why does that happen? That happens because the spinothalamic tract crosses in the center of the cord, the anterior commissure, right? So when the intramedullary tumors involve the center of the cord, this is how the patients present. Am I clear, or do I need to make this clear?
Assalamualaikum. Madam, can you please repeat it?
Okay. And Dr. Sana, what ends up happening is the spinothalamic tract is the tract that is carrying the pain and temperature fibers, right? What ends up happening is this tract decussates in the anterior commissure. Anterior commissure is, let me draw here. Just give me a minute. So we have, can you see my screen?
Yes, yes.
So imagine, and this is a very poor representation of the spinal cord, by the way, but we have central canal here. This is the cord substance, and this here is the anterior commissure, right? And the spinothalamic tract is crossing in this anterior commissure. What ends up happening is, if the tumor grows somewhere here, it ends up involving the spinothalamic tract as well in the process. And that leads to loss of the ability to feel pain and temperature at the level of the tumor. Did I make myself clear?
Yes.
So this is a very common presentation, dissociated sensory loss. And since this usually the ependymomas involve the cervical cord, so this might be present in the hands. Symptoms are symmetric. Why are they symmetric? Because we have already discussed that the tumor involves the midline. So the symptoms are symmetric. There will be burning hand syndrome. Why is that? Because the tumor is involving the cervical region. Patients may complain the feeling of painful burning or tingling sensation. There would be motor weakness involving all four limbs. There will be nocturnal pain, which we all by this point know that it is a very specific feature of spinal tumors. So, moving on to radiology. MRI is the gold standard, both with and without contrast. Tumors are classically centrally located. If you see the axial sections, I have just remembered that I did not include any axial sections. And they cause symmetric expansion of the cord, as somebody wrote in the chat that this is a pregnant cord. T1 weighted, isointense to hypointense. T2 weighted, typically hyperintense. Contrast is usually, the uptake is usually homogeneous. They enhance really well, but sometimes they might not enhance, and not enhancing does not mean that the tumor is low grade. I think I have made this a very good point to remember throughout these sessions. Enhancement is not a very good judge of the grade of the tumor. So, cap sign. I think all of you are familiar with this. Cap sign is a rim of extreme hypointensity at either poles of the tumor. You have a pole, let me draw here. This is the tumor, okay? Assuming that this is the tumor, what ends up happening is there might be a very dark rim here, or there might be a very dark rim here. This is called the cap sign. How will this present on T2 weighted images? You will see that the tumor itself is bright. Let me draw that. The tumor itself is bright like this, okay? And the cap sign is like this. It could be this, it could be just this, it could be both, depending on the tumor. Have I made myself clear?
Yes.
And why does that happen? Because these are usually hemosiderin deposits from chronic microbleeding. It is highly suggestive of ependymoma, but there are some other tumors, I think paraganglioma, and there's one more that might show cap sign. So this is not 100% exclusive. Moving on. If you see, I think you are going to remember the diagram. The tumor is hyperintense on T2 weighted images. There is a cap sign above here. There's a cap sign below here. Hypointensity on T2 weighted images. You see that there is significant peritumoral edema, which is involving the cord, and there is disruption of the CSF column. So, what does this show that this did not have? What are these cysts called? What are these cysts called? And what does this have? Can someone comment on this? Nobody? Okay, I think I did introduce the concept of satellite cysts, right? Satellite cysts are what you see here on the poles. And what you see here, I will change the color of my marker. What you see here is intratumoral cysts. So in ependymomas, you are going to find both. Sometimes one, sometimes the other. You might find only the satellite cyst. If you look at this tumor, you see that the lesion is located here. There are a lot of cysts above and below. These are satellite cysts. If you see this, there is no satellite cyst, but you can still see the cap sign. Are you all with me?
Yes.
So if you see here, this is the cap sign here. There's a very small cap sign on the above on the superior pole of the tumor as well. But the cysts are within the tumor itself. They are not at the poles. So these are the intratumoral cysts. In the first image, these are the satellite cysts. And when you see the last image, there are both the intratumoral cysts and I have just cleared it up so that it's easier for me to write. These are the intratumoral cysts. And these ones are the satellite cysts. Have I made myself clear?
Yes.
So both
Yes,
of
ma'am,
these
yes.
can be a feature of ependymoma. And the next time you look at a lesion like this, you would not confuse them for astrocytomas. So this is slightly atypical in the sense that this has a huge syrinx above the lesion. And if you see that the lesion is very ill-defined, which is also followed by some sphingohydromyelic changes below the lesion. And the lesion is so ill-defined that you cannot completely demarcate where the lesion is ending and where the cystic portion and the sphingohydromyelia is starting. Moving on, let me click. So, grade 2 progression-free survival is really good, 70% in children, 90% in adults over 5 to 10 years. Grade 3 prognosis is generally really, really poor. Okay, somebody wrote in the chat something. Also, septatus shringohydromyelia, yes, that's right. Septatus shringohydromyelia is there, satellite cysts are there. We have spinal ependymomas, mycian amplified. Now, this is a relatively newer group, and I think there are some 200 or something case presentations that have been recorded so far. But because this is a very aggressive variant of a spinal ependymomas, WHO CNS groups this and treats this as a separate entity. There has been no WHO grade assigned to this. These are rare. Histopathologically, they show brisk mitotic activity. There is necrosis, there is microvascular proliferation, and by definition, mycian amplification is present in them. As I mentioned, no WHO grade has been assigned. These can be intramedullary. They can be intramedullary with exophytic component, are only extramedullary. And what is more amusing is that even if they are extramedullary, they still end up causing a lot of cord edema. And often on presentation, we find leptomeningeal involvement. There is sugar coating or what we call drop mets, hence very, very poor survival. Cervical or cervicothoracic cord involvement is common with them. And if you see, I think that this is a very good representation of what intramedullary with extramedullary component looks like, because you see that this is where the cord is ending somewhere. My arrow is slightly off, but it is going out. And on this side, you still see the cord edema. On the other side, you see that the CSF column is obstructed. They are vividly enhancing. They show some intratumoral cysts as well. And the same rule applies on them. Even if they're not enhancing, that does not change their grade. Very poor prognosis and frequent recurrence. This is a comparison just so that it's easier for you to remember. If you don't understand this through the session, you can always go back to the PPT and take a look. So the location is usually intramedullary for classic spinal ependymomas. For mycin amplified ependymomas, they are often extramedullary or intramedullary with exophytic components. Classic variant is often well circumscribed. The mycin variant is infiltrative, poorly defined. Why does that matter for us? Because GTR is not often possible in them. Usually, classic variant is solitary, and mycin on presentation is frequently disseminated with leptomeningeal metastasis. Capsine is very common in the classic variant, growth rate is slow, and prognosis is excellent. While mycin amplified ependymomas do not often show the classic variants, the growth rate and the clinical presentation, the natural history of the disease is very, very rapid. And the prognosis is very poor. Recurrence rate is pretty high. So that's it for today. That's a wrap. Any feedback, any questions, all of them are welcome. 2 sessions from last week are still remaining to be uploaded on the YouTube. I think I will upload them tonight, inshallah. Any questions, any feedback? You can write in the chat box if you don't want to turn on the mic.
Jazakallah, ma'am. Bundle of thanks.
Okay, everyone. I see no questions. That's a wrap for today. Thank you so much for joining.